A very good morning. Welcome everyone for the monthly specialty update organized by the Ceylon College of Physicians. Today marks a special occasion as this is the last Ceylon College of Physicians specialty update of the year 2025. Today's exciting session consists of important topics covered from the fields of rheumatology and rehabilitation and will be held in two separate symposia. Before we start off, to welcome this gathering, I would like to cordially invite the President of the Ceylon College of Physicians, Vidya Jyoti, Professor Prasad Katulanda, to the stage.
Good morning, ladies and gentlemen. Dr. Jayatri Jagoda, President, newly elected President of the College of Rheumatologists, and fellows and members of the Ceylon College of Physicians and the College of Rheumatologists, ladies and gentlemen. It's my great pleasure as the last academic activity of the college this year to welcome all of you to this very important symposium jointly organized by the Ceylon College of Physicians and the College of Rheumatology on update on rheumatology. So we are going to discuss very important things, something which is not very frequently discussed, symposium on myopathies and also case-based discussions on myositis, myopathies, as well as very important another topic for patient management, as well as for those who are studying for their postgraduate exams. Very frequently asked area, the systemic lupus erythematosus. So I think we have a very excellent panel from the College of Rheumatology to take this forward today, and hope that all of you will enjoy as well as have a very productive session in the today's specialty update. Thank you very much.
Thank you, sir. And now, to say a few words of enlightenment, I would like to cordially invite over the President of the Sri Lanka College of Rheumatology and Rehabilitation Specialists, Dr. Jayatri Jagoda, to this stage.
Good morning. Thank you, Dr. Katulanda, for introducing me. It's the last specialty update on CCP, and it's the first academic event that I am participating as the president. Today's specialty update, there are, as Dr. Katulanda said, consists of two symposia on myositis and SLE, and there will be a very important shorts for postgraduate students by Dr. Munidasa, which I think will be very helpful for the PG trainees. And I welcome you all and thank you all for the participation of this specialty update done in collaboration with CCP and CSRRSL. Thank you.
Thank you, Madam. The first symposium organized for today is based on the all-important topic of myopathies. The first speaker to start off this exciting topic is Dr. Utpala Disanayaka. Dr. Utpala Disanayaka, MBBS, MD, MRCP, is a consultant rheumatology and rehabilitation specialist currently attached to the National Hospital of Sri Lanka. She completed her MBBS degree at the Faculty of Medicine, University of Peradeniya in 2004 and received her MD in Rheumatology from the Postgraduate Institute of Medicine, University of Colombo in 2010. She is also specialist certified in rheumatology from the Royal College of Physicians in the year 2016. She is a member of the Ceylon College of Physicians and a member of the College of Specialists in Rheumatology and Rehabilitation of Sri Lanka and a member of the Royal College of Physicians, London. The topic she has chosen for today is unveiling the spectrum of immune-mediated myopathies. With that, I would like to hand this session over to Dr. Utpala Disanayaka to conduct her session.
Good morning, everyone. Thank you very much for kind words of introduction. And I'm the consultant rheumatologist from National Hospital, Kandy. I must thank CCP as well for giving us this opportunity to discuss this complex multisystemic disorders to show that we too do manage complex multisystemic disorders because sometimes we do see some delays in referrals. So we are not just pain doctors. My topic is unveiling the spectrum of immune-mediated myopathies. Immune-mediated myopathy is as same as idiopathic inflammatory myopathy. Some people prefer to use immune-mediated myopathy because in certain diseases we don't see inflammation in the muscle biopsies. Therefore, now there is a little controversy. So these two terms are used interchangeably. Why I wanted to choose this topic was that there is a significant difference in the classification which happened over last 1 to 2 decades. We used to call everything polymyositis when there was inflammation in the muscle in past. Then it changed to polymyositis and dermatomyositis. There were 2 groups, but modern classification shows 5 distinct diseases. They differ in pathophysiology, organ involvement, treatment responsiveness, and there is association with there is a difference in complications as well, like interstitial lung diseases and malignancies. And if we misclassify the disease, we can mistreat the patient. Therefore, it's really important to know the classification of these diseases. Though the biology is complex, the clinical logic is very simple. You will understand that at the end of the lecture. So I will be discussing about how myositis classification has changed, the main myositis groups today, antibodies and what they mean, key clinical patterns, how we diagnose, and some take-home points. So these diseases have progressive muscle weakness in common with some extramuscular manifestations, and this progressive muscle weakness is very insidious in onset. And they do show inflammatory infiltrates of varying degrees in muscle tissues. And I want to emphasize you on the incidence of the disease. So this is the group of, sorry about the clarity, immune-mediated myopathies. This is systemic sclerosis. You have SLE here. So compared to, this is rheumatoid arthritis, compared to the incidence of other diseases, you can see how uncommon and how rare these disorders are. The prevalence is around 0.2 to 2 per 100,000 person years. So it's very uncommon. So as I said before, it was only the polymyositis when it was first recognized around 1886, and then later they identified that some patients show some cutaneous manifestations. Then it was classified as polymyositis and dermatomyositis. When there was skin involvement, it was categorized as dermatomyositis. But with time, the classification changed. Initially, the 2 groups were polymyositis and dermatomyositis. Then the clinicians realized that the patients who is supposed to have polymyositis, some patients actually act differently and they respond treatment to differently. Then they realized that there is this group called inclusion body myositis, which was mistakenly categorized under polymyositis, and they usually do not respond to usual treatment. So the actual polymyositis is now becoming rarer and less in number. And this is overlap myositis, antisynthetase syndrome. You can see when these patients didn't have significant cutaneous involvement, they were categorized under polymyositis. And sometimes, since there were skin involvement, initially they were categorized in dermatomyositis. So this is how the landscape changed in myositis. So these are the 6 main types under immune-mediated myopathies. You have dermatomyositis, polymyositis, antisynthetase syndrome, inclusion body myositis, immune-mediated necrotizing myopathy, overlap syndromes, or the myositis associated with other CTDs. Variations in extramuscular clinical manifestations and specific findings on muscle biopsies and disease-specific serologic abnormalities help to distinguish each category from one another. Right. So let's move on to each type. Now, under dermatomyositis, we have 3 main types: classic dermatomyositis, clinically amyopathic dermatomyositis, we call it CADM, and MDA5 associated dermatomyositis. These are the 3 main types under dermatomyositis. Classic dermatomyositis patients present with symmetric proximal muscle weakness, elevated muscle enzymes, and characteristic cutaneous manifestations. Cutaneous manifestations often precede or accompany the muscle disease. Therefore, it is really important for you to identify these characteristic cutaneous manifestations because most of the time they precede the onset of muscle disease. Muscle weakness present at diagnosis in only 50 to 60% of the patient, and they can have myalgia and muscle tenderness as well in some patients. Anti-nuclear antibodies can be positive in dermatomyositis, and usually it is nuclear type. These are the antibodies associated with dermatomyositis: anti-MI2, anti-NXP2, anti-TIF1 gamma, anti-SAE. All these things are nuclear ANA pattern, and even if the ANA is cytoplasmic, still it is clinically significant with regards to myositis because anti-MDA5 is a cytoplasmic ANA antibody. And it is really important that these myositis-specific antibodies are not there to diagnose the disease, but these specific antibodies guide the phenotype recognition and to detect the prognosis, decide on the prognosis and other disease-associated complications. These are the cutaneous manifestations. The pathognomonic features are Gottron papules and heliotrope eruption. And there are the characteristic and useful cutaneous manifestations. They are Gottron sign, photodistributed erythema, poikiloderma, nail fold changes, scalp involvement, and calcinosis cutis. So this is famous Gottron papules. They are raised lesions, plaque lesions, papules, and reddish violaceous lesions on MCPs and PIPs. Sometimes you can see this linear continuation of these plaques over the fingers up to PIP joints. This is Gottron papule, which is pathognomonic, and this is Gottron sign. Usually, Gottron sign is a macule. They are not raised and flat. Sometimes there can be atrophy as well. The Gottron sign is seen usually over extensor surfaces like knee, elbow, and malleoli. This is again pathognomonic, the heliotrope eruption. And they present to us with heliotrope eruption and facial erythema. Sometimes you will not be able to recognize the heliotropic eruption separately. When they present with facial erythema, sometimes it is very difficult for us to differentiate it from SLE because they don't have muscle involvement when they first present. So one thing to differentiate is that usually in SLE, nasolabial folds are spared. Here, the nasolabial fold also involved, and this is often pruritic. Usually, the SLE skin erythema is not pruritic. This is severely pruritic. And this is again the Scholl sign and the V sign. This is again photosensitive eruption. These are characteristic signs in dermatomyositis. This is psoriasiform rashes in scalp. It is really important to separate hair and look at the scalp. Sometimes not only psoriasiform eruptions, you can just see erythema of the scalp. And this is famous Holster sign. This is calcinosis cutis. This is one of our patients. I don't know if you can see the calcinosis there, and calcinosis also seen in the dermatomyositis. And the other thing is, it's really important to know the nail fold changes. As I said, sometimes they might not have the other features. They will come with some constitutional symptoms and they will only have the nail fold changes. This is a normal nail fold, and you can see ragged cuticles here. And this is the normal capillary loops. You can see normal capillary loops here. And if you look at dermatoscope, or if you use your ophthalmoscope, which is not very good at looking at the capillaries, you can see these capillary dilatations, and this is capillary drops. You can see these capillaries here are not there. So the capillary drops. And dermatomyositis, of course, is a disease where the capillaries are involved even in the muscle biopsy. So you have to look at these things, nail beds, carefully. So there is increased malignancy risk, as we all know, and the risk is highest when it is associated with anti-TIF1 gamma positive patients. And types of malignancy generally reflect those seen in the general population. So you don't have to look for other malignancies, but usual what you see in the general population. Thorough malignancy screening is essential in dermatomyositis patients, especially in high-risk ones. So the clinical pearl is, in dermatomyositis, characteristic skin findings may precede or exist without muscle weakness. Therefore, it is really important for you to identify these classic typical skin manifestations. Recognizing the rash should prompt evaluation for muscle involvement, interstitial lung disease, and occult malignancy, especially when it is associated with these antibodies. Then clinically myopathic dermatitis. Again, what I want to say is it's same as the dermatomyositis. The only difference is there's no muscle involvement, but even if there's no muscle involvement, it is not a benign disease, and absence of muscle weakness does not imply benign disease. And here we call it provisional CADM when it is more than 6 months without muscle involvement. We confirm it when there is no muscle involvement at 2 years. Then the famous MDA5 associated dermatomyositis. The most important thing is the characteristic cutaneous features. Ulcerated gutterance, we all know that. And these can sometimes lead to digital necrosis as well. Painful erythematous palmar macules and papules, which is not seen in other types of dermatomyositis. Prominent non-scarring alopecia, oral ulcers and tender gums. Mechanics hands can be there in MDA5 associated dermatomyositis, and calcinosis, which is less common. And they can have arthritis, and their myositis is usually minimum or absent. So there will be significant skin involvement and significant lung involvement. They have high risk of ILD, as well as the ILD is very rapidly progressive. Most of the time we do see these patients in ICUs. So this is the classic ulcerated guttural papules. You can see the ulcers in the face, and these are the papules over skin creases in the palms. So you cannot miss these things, but most of the time when somebody see this, they will never suspect a rheumatological disease. Instead, they can suspect the other infective causes like TB, skin TB, those things. Therefore, they are usually referred to physicians or rheumatologists later. Recognition of the cutaneous phenotype is crucial to identify MDA5 associated dermatomyositis, prompting early ILD screening and close pulmonary monitoring. If these antibodies are there, if these skin manifestations, not antibodies actually, skin manifestations are there, because the in our setup, autoantibody screening is not available in government sector. It's very costly, more than 50,000. Therefore, we have to diagnose the disease most of the time clinically. Therefore, it's really important for you all to get used to identify these skin manifestations, which will help to pick the ILD early and treat it early. Then the famous anti-synthetase syndrome. And onset is acute. This is compared to other diseases now. Dermatomyositis is usually insidious onset, subacute onset. The weakness or the skin manifestations will develop over weeks to months. But anti-synthetase syndrome is little different. Its onset is acute, and they usually present with fever. And they will have they have ILD as well. Most of the time, they will present to the respiratory ward with suspecting possible chest infection because they have constitutional symptoms, fever, and difficulty in breathing, usually acute onset. But again, then you have to know these characteristic clinical features. They can have non-erosive inflammatory arthritis and mechanics hand and hiker's feet. Again, I told you these things are rare. So mechanics hands can be there in mechanics as well. That you should understand. Our farmers, the people who work doing manual work will have mechanics hand anyway already. So if they develop fever and chest infection, don't jump and do the investigation thinking that it's anti-synthetase syndrome. Therefore, it's really important to assess everything clinically. So mechanics hands and hiker's feet, Raynaud's phenomenon, and unexplained fever. That's very important. So common diseases are common. Key diagnostic support is anti-tRNA synthetase antibodies. They are the famous anti-Jo1. Those days, if anti-Jo1 is positive, we used to call it polymyositis when we were students, but now it's a separate disease entity. Anti-Jo1, PL7, PL12, EJ and OJ are the common antibodies. And here, usually ANA can become negative in these patients, but still, these anti-tRNA antibodies can become positive because the method that it detects is different. It is the immunoprecipitation. So usually it is defined when there are two characteristic clinical features and anti-ARS positivity. Classifications are not necessary for diagnosis, but these classifications, if you go and read, you can just look at the weight given for each component. So that will help us to have an idea about the disease. Right, this is a mechanic hand, Raynaud's, and ulcers in feet in one of our patients who had anti-synthetase syndrome. So anti-synthetase syndrome should be suspected in patients with ILD or inflammatory arthritis associated with mechanics hands or Raynaud's, even in the absence of overt myositis. Then polymyositis. There is female preponderance, rare in pediatric population. Increasing evidence shows true polymyositis is rare. Many cases previously labeled as polymyositis are now better classified as anti-synthetase syndrome with lack of characteristic rash, overlap myositis associated with other connective tissue diseases, inclusion body myositis, and immune-mediated necrotizing myopathy. Because those days, when the biopsy shows the necrosis, we assumed that it was a sampling error. But later only we realized they have a different phenotype, and where this necrosis is the typical feature of this type of this immune-mediated necrotizing myopathy. Usually, again, they present like, polymyositis patients present with muscle weakness mainly because they do not have skin manifestations. Therefore, they usually present to us late. They compensate as much as they can, then they present late. And there's 90% of patients with polymyositis have muscle weakness at presentation. Usually, weakness is symmetrical and proximal, no extramuscular manifestations. This is the distribution. It's really important to know the commonly affected muscles: deltoid, hip flexors, abductors, and extensors, and neck flexor weakness with relative sparing of extensors. So they cannot bend their neck. They cannot lift their neck from the bed. And distal weakness is usually milder, and muscle atrophy is usually not seen. And insidious or subacute onset, gradual progression of weeks to months. Very occasionally, they can present acutely. True polymyositis is rare. proximal weakness with elevated CK should prompt exclusion of immune-mediated necrotizing myopathy, anti-synthetase syndrome, and other myopathies to diagnose polymyositis. Then immune-mediated necrotizing myopathy, again, the clinical picture is like polymyositis, but they have very high CK levels, usually more than 20,000. Key pathological features: extensive muscle fiber necrosis in the muscle biopsy, minimum inflammatory infiltrate on muscle biopsy. These features distinguishes this IMNM from polymyositis. And the associated antibodies are anti-HMG-CR antibody with or without prior statin exposure, and anti-SRP associated IMNM. So it should be suspected in a patient who is presenting like polymyositis but having very high levels of CPK. Then the biopsy will confirm it with antibody testing. Inclusion body myositis, again, I think we do miss this diagnosis because it's different to the classic presentation of polymyositis. It affects older individuals and male predominance, and usually there's asymmetric weakness and distal weakness. You have to know the deep finger flexors are affected, and if your patient cannot extend your flex fingers, then suspect inclusion body myositis. And if this patient's having quadriceps weakness with frequent falls, because we can attribute that to osteoarthritis since it's a male person, please consider inclusion body myositis. Relative sparing of deltoids. These antibodies we cannot do here. Muscle biopsy will show these rimmed vacuoles. So, if an older patient, a man present with slowly progressive asymmetric weakness involving finger flexors and quadriceps, think of inclusion body myositis. So overlap syndromes are the myositis associated with other connective tissue disorders. Usually, they do not have significant proximal muscle weakness. Usually what happens is on investigation, we do detect high CPK levels. Mild CK elevation with or without minimal weakness in a patient with another connective tissue disease should prompt consideration of overlap myositis. So it's again the same thing. Now, when you know the skin manifestations and other features, you can understand why these things were separated from the previous two subtypes. Right, so the diagnostic approach. Initial evaluation is done by history and physical examination. So we don't need anything else to diagnose these immune-mediated myopathies. It's all history and physical examination. So history actually is to confirm the diagnosis and exclude other disorders like hypothyroid myopathy and metabolic myopathies. So you all know, on examination, it is really important to examine the patient from head to toe. You have to expose the patient, look at the patient's back, separate hair, look on the scalp, so nail fold, you have to examine the patient thoroughly. And then the investigations. Creatine kinase is the most sensitive muscle enzymes. Usually the amount of CK elevation will help us to diagnose inclusion body myositis, usually which is less than 15 times normal. That means usually around, it's usually around less than 10,000. And if it is very high, around more than 20,000, suspect immune-mediated necrotizing myopathy. And one other thing is, CK can be normal with ongoing active disease. That is again important. Other muscle enzymes are liver, AST, ALT, and LDH. Inflammatory markers, usually normal or mildly elevated. When it is elevated, consider infection, malignancy. And anti-synthetase syndrome, you can have elevated inflammatory markers and anti-MDA5 disease. And you must remember that TSR can become unreliable in patients who is receiving, in patients who receiving IVIG. These are the autoantibodies you have to do. You should know these names actually, because at least few names. Again, as I said, nuclear, cytoplasmic, both patterns are important in myositis. You have myositis-associated antibodies and myositis-specific antibodies. So this is a summary of that. These are the myositis-associated antibodies, usually antibodies seen in other CTDs that may be associated with myositis: anti-Rho, anti-LA, anti-SM, anti-RNP, anti-Rho52, anti-Rho60, and anti-PMSCL, anti-COO. Electromyography will show only the myopathic pattern. It will not confirm the diagnosis. It's again your history. MRI will be helpful because the sampling error is less, because you image a large proportion of large area of muscles, so you will pick myositis quickly. Again, it is non-specific. These are the main histopathological changes. Polymyositis, it's, as I said before, dermatomyositis, usually there is microangiopathy and vasculopathy in the muscle biopsy. There is a classification criteria. This is the link to that web-based calculator. This is not necessary for diagnosis, but these classification criteria will help you to know how important it is to know your clinicals, because you have to pick the heliotrope, whether heliotrope rash is there or not. So you should be able to identify heliotrope rash. Then Gottron papule, you should be able to identify Gottron papules. Therefore, you must see patients as much as possible to learn these physical signs. Then the these things are done for diagnostic evaluation, basic blood test, CK, EMG, muscle biopsy, and imaging, MRI. But post-diagnostic evaluation is done to assessment for ILD, screening for malignancy, and evaluation of organ involvement. Now here, baseline, in all patients with myositis, you should do chest X-ray and pulmonary function test. Now in scleroderma, at the beginning, we do screen everyone with all three, chest X-ray, pulmonary function test, and HRCT. Here you're not going to do that. But if there is high-risk antibodies like antisynthetase antibodies and MDA5, you might consider requesting for HRCT, but otherwise not. Screening for malignancy in all adult patients, you have to, it's again done mainly by the history and examination, and age-appropriate cancer screening should be done for everyone, but at high risk of patients may require additional investigations or imaging to screen for malignancies. Again, like anti-TIF1 gamma antibody. Then evaluation of organ involvement, esophageal involvement, and cardiac involvement. So you have to look for these things, and these are the tests to perform. So management depends on subtype, and because that's why I told you it is really important to know the subtype. Inclusion body myositis typically unresponsive to immunotherapy. So we live in a resource-poor setting in a country, so you cannot waste your IVIG, methylprednisolone, and rituximab for a patient who is not going to respond to it. So identify the subtype earlier. And other immune-mediated myopathies generally immunotherapy responsive. And treatment should be individualized depending on the severity and duration of weakness, presence of extramuscular involvement, underlying malignancy, and patient's age and comorbidities. So, as I said, in certain myopathies, it's the ILD which is dominant. So you have to treat the ILD but not the myositis. So it is according to that patient's presentation and clinical involvement. First-line therapy, glucocorticoids and steroid-sparing agent, methotrexate, MMF, azathioprine, and rituximab. IVIG is the only FDA-approved treatment for dermatomyositis. IVIG also included in this treatment. Right. So in inflammatory myopathies, prognosis is determined more by subtype and extramuscular involvement than by muscle weakness alone. That you must remember. And supportive care, it's really important. You suppress the inflammation by giving these immunomodulators, but the damage has already happened. It is said that now the damage to your ultrastructure can retain there for about 10 years. Earlier, we didn't start aggressive physiotherapy from the beginning. Now the understanding is different. You should start active physiotherapy from the beginning. And osteoporosis prophylaxis, aspiration prevention should be considered. Right, and then when you treat the patients with inflammatory myopathy, usually you're not going to check CK every day. So you should give some room for this, some time for these muscles to improve. Usually they recommend to do it 2 to 4 weeks initially. Ideally, it should normalize by less than 6 months. Sometimes patient can have persistent elevation without symptoms, but if there is significant clinical improvement, you are not going to treat those elevations. Once everything is normalized, monitor every 3 to 6 months or soon if symptoms worsen. Clinical assessment, MMT8 is the proper way of assessing the muscle involvement, but in heavy clinic you cannot do that every day. So what they suggest is deltoid arm abduction, the what we usually do, and neck flexors. Just check those two. And in lower limb, check the quadriceps and hip flexors in clinics to see if they are symptomatic. Right, so that's the end of my talk. What I want to emphasize is diagnosis is mainly clinical, so it's your history and examination. Remember, these diseases are very rare. Therefore, don't jump and do antibody testing, which is very costly. Therefore, do it when there is, even if it is not just academic, it is used clinically, but when there is high pretest probability. Do not treat CK, but look for the clinical features and the trend. Thank you.
Thank you, madam, for that informative presentation. Next up, we have a case-based discussion on myositis, describing the practical aspects and challenges in treating a patient with myositis. To introduce the patient and present today's case, I would like to cordially invite over Dr. Madhushika Nilanga Costa. Dr. Madhushika Nilanga Costa is a senior registrar in rheumatology and rehabilitation, currently attached to the National Hospital of Kandy. She completed her MBBS degree at the Faculty of Medicine, University of Sri Jayawardhanapura, with a second class in the year 2010. She has received her MD in Medicine from the Postgraduate Institute of Medicine, University of Colombo, in 2024. Without further ado, I would like to again invite over Dr. Madhushika Nilanga Costa to present her case on managing a patient with myositis.
Thank you for the introduction. Good morning to you all. I would like to thank CCP and CSRRSL for this opportunity. So I'll go on with my case presentation. This is a 55-year-old male who is a security officer, was diagnosed with diabetes mellitus for 3 years, was on diet control without, not on any medication, no known allergies, and a non-smoker. He first presented with progressive facial swelling with itching and redness for 1 month duration. Initially, he was, within this 1 month, he was treated as for an allergic reaction. When it was not resolved, he was referred to a dermatology clinic. There was no evidence of any allergic, like angioedema, stridor, difficulty in breathing or anything. And interestingly, patient was denying photosensitivity. The dermatology team was considering contact dermatitis and rosacea in this patient, and they did do a biopsy, which came as rosacea, and they treated accordingly. They also referred this patient to the medical clinic for management of comorbidities, where he was started on atorvastatin and hypoglycemic agents. And then after 2 weeks of starting treatment for dyslipidemia, patient presented again for a medical ward with thigh pain followed by difficulty in standing from squatting for 1 month duration. There was associated myalgia and the symptoms have been progressively worsening, and there was no dark color urine. And at the presentation also, he had the same erythematous rash, which was pruritic, involved in the face and the upper body, and there were no other constitutional symptoms or other systemic symptoms. No family history of malignancies either. So at this point, what are our differentials? They correctly considered drug-induced myopathy because patient was recently started on a statin and immune-mediated myopathies. This is the initial evaluation where they found to have a high ESR of 100 and AST and ALT was elevated with a pattern of AST more than ALT. Rest of the investigations were normal, including renal functions and electrolytes. At this point, they did a rheumatology referral, and when the rheumatology team evaluated the patient, the history was suggestive of a proximal muscle weakness with myalgia, with lower limb involvement more than the upper limbs, and still there was no history of any dysphagia or difficulty in breathing. And interestingly, these symptoms started even before starting statins, and which has been progressing slowly. And patient did not have any other features of connective tissue disorders like Raynaud's phenomenon, and patient still strongly denies photosensitivity or any other symptoms. So at this point, our diagnosis was with the disease dermatomyositis, and this is our patient. I think you can see clearly the patient's erythema of the face involving even the nasolabial folds, and periorbital swelling, and I think you can appreciate the redness of the anterior chest wall, suggestive of V-neck sign. And he also had a shawl sign, which I do not have a picture to show. And but there was no other features of dermatomyositis, cutaneous features, and there was no respiratory involvement at this point. So this is the muscle evaluation of this patient. Proximal involvement more than the distal muscles and lower limbs more than the upper limbs. And the MMT8 score was 102 out of 150. Just to give you an idea of what is this MMT8, that is called manual muscle testing score, which is used by rheumatologists and physiotherapists to assess, objectively assess the muscle weakness in patients with myopathies. This is just to get an idea on follow-up whether the patient is deteriorating or improving. This is the interpretation, how to give the values. And so we proceeded with the evaluation. His CPK came as more than 11,000. And the rest of the investigations we did to exclude other causes like thyroid functions were normal. And as mentioned in the previous lecture, basic malignancy screening was negative. There was no cardiac involvement or lung involvement. And the EMG was suggestive of myopathic disorder with possible myositis, where it showed spontaneous activity with fibrillations. ANA was significantly positive with a nuclear speckled pattern. And at this point, we started treating the patient. We did do a muscle biopsy and repeat skin biopsy. While awaiting the results, we started treating him with IV methylprednisolone pulses, followed by oral prednisolone, 1 milligram per kg per day. While receiving the treatment, while in the ward, patient's symptoms progressed rapidly over days despite the treatment. His weakness was progressing. He could not sit on bed or turn on the bed, and he developed dysphagia for liquids, but still he did not have any difficulty in breathing. So this is the re-evaluation of the patient. You can see there was significant involvement of even distal muscles with neck muscle involvement, significant neck muscle power was 1 out of 5. And MMT8 score was reduced to 68. So at this point, her CPK levels were reduced for 9,000, more than 9,000, but AST/ALT were also coming down, but still patient was clinically deteriorating. And myositis profile was not available at this point. Muscle biopsy was available, which was suggestive of dermatomyositis. Skin biopsy was also, repeat skin biopsy was also suggestive of dermatomyositis. So what are the therapeutic options now? Now the patient with dermatomyositis having rapidly progressive disease despite steroids. Madam?
Do you like to answer this? This patient was given steroids actually, 1 gram. We do speak about low-dose steroids in other diseases, but in myositis we still give 1 gram methylprednisolone pulses. Now, as I said before, even if the CK was improving, these things will not correlate sometimes. Now, patient was clinically deteriorating and having significant neck muscle flexion weakness. So at any point your breathing can get affected. So what do you consider at this point? Yeah, we have given 2 options, IV immunoglobulin and Plex. Yeah, I will proceed. So immunoglobulin is actually FDA approved and clinically tested treatment, actually one of the the only one clinically tested treatment, immunoglobulin. But what you should remember is that we do plasma exchange very frequently. That is helpful, but you must remember in this patient sometimes we could have done plasma exchange because patient is going to a possible respiratory arrest. In those instances, of course, you can use plasma exchange just to remove the immune complexes to buy time for your immunomodulators to act. Because the effect of plasma exchange will last only about a week. It doesn't go up to months because you just remove the immune complexes and your underlying mechanism is still going on. So immune complexes will be forming, therefore, but still you can use it. But don't use Plex as the first line always. Instances like this, you can consider plasma exchange to buy time for your original first line treatment to work. But IVIG, in contrast, the effect will last about a month. That's why we usually repeat in resistant patients IVIG monthly. So what I wanted to emphasize here, IVIG you can use and the effect will last longer, but if your patient is going to develop impending respiratory arrest and you cannot find a ICU bed for your patient has not gone to arrest, but when significant neck muscle weakness and now CPK is improving, so you know that disease is improving, but the clinical response is lagging behind. Then at this point you may consider Plex to buy some time.
So we went ahead with IV immunoglobulin.
Actually, yeah, one thing, and in this patient, actually, this patient was managed in 2023. This famous IVIG problem was there, so we did not have IVIG at the beginning, but by day 10 it was available for us.
So we proceeded with IVIG, 2 grams per kg per dose for 5 days, divided doses. And then a patient started improving, and this is the investigations. And as you can see, there was a drop, steady drop in CPK levels, but again there was a rise. But patient was improving. So do we have to act on this?
Yeah, that is another thing we see. Now, what the experts say and the literature say is, even if your clinical involvement is static, your muscles are not getting worse, but they're static. But if your CPK is improving, you don't have to worry. You do not have to load them with all the immunomodulators. So you can wait because the clinical response can lag behind the CPK improvement. But in this patient, now CPK was increased by less than 1000. So what they usually say is if the difference is less than 1000 and if there's no worsening in clinical improvement, you don't have to do anything. Just look at the trend since patient is clinically getting better. So if clinically or CPK wise, if patient is showing some improvement, then you do not have to panic and treat them with all the immunosuppressants because then patient will die of infections. Therefore, just give some time for these medications to act if patient is starting and showing at least improvement in one parameter. So even if the CPK was 7,380 here, you do not have to do anything. All you have to do is monitor the patient.
Now, what are the maintenance therapy options in this patient? Now, patient is on steroids and improving.
If you go back to the previous slide, you can see now this patient's AST level is dropping, but you can see the liver enzyme, ALT is rising. Right, so this patient had CPK, fatty liver in ultrasound scan as well. So these are the practical problems we do face in wards. Now this patient's liver function is getting affected. So, so you have to remember these things also when you make a therapeutic option. Yeah, so these are the drugs available for us. So azathioprine, methotrexate, mycophenolate, mofetil. Usually what they say is azathioprine and methotrexate as the first line treatment, but still you can consider mycophenolate, mofetil as well. And in this patient actually, now there is some liver involvement as well. So and it was rising. And there was fatty liver also, and patient is on steroid that will further worsen the liver enzyme. So what do you think is the best option at this point? When there is some liver involvement as well. And we do not know what the trend is. Now it's in increasing trend. Unfortunately, alkaline phosphatase and gamma GT is not there, but it was also slightly elevated. Yeah, rituximab will be a best option. So even in CLCD patients, when we need immunomodulators, we consider rituximab.
Okay, we gave rituximab to the patient. And then patient was steadily improving, and we were able to discharge the patient on azathioprine. Once as you can see, the liver functions came steadily down, and patient improved. And at this point, we started the patient on azathioprine on discharge. This is then. By this time, the myositis profile was available, and Me2 antibodies were strongly positive, and rest of the antibodies were negative. Now, at this point, what is the significance? So, the significance is anti-Me2 antibodies are not associated with underlying malignancies, and it is known to be associated with good response to the treatment. So, we did the age-appropriate malignancy screening only. So, since there is less risk, we did not go for the detailed malignancy evaluation.
And MI2 is associated with rapidly progressive disease as well, though it responds well to treatment. So that's what we saw in our patients. So that's the importance of these antibodies actually.
As I mentioned earlier, we discharged the patient on azathioprine, and patient came again for the second dose of rituximab with elevated liver enzymes with the transaminitis again, with ALT more than AST, and a thrombocytopenia. We had to switch azathioprine to MMF at this point because azathioprine was not an option at that point. Now, with that, patient started to improve and liver functions came down. Then during the follow-up, patient was steadily improving and CPK was also steadily reducing. But at 3 months review, the patient's CPK was again rising. But clinically, there was no deterioration. Now, at this point, should we escalate the treatment?
Again, it's the same answer. So the rise is not significant, and you should look for the trend. And there's no clinical worsening. You're not going to treat, but monitor the patient. And when you're considering the maintenance treatment, the other thing you have to consider is what this patient is actually having. So when there's dermatomyositis, when there's skin involvement, usually azathioprine and MMF will look after the skin more than methotrexate. So you can consider that for maintenance therapy over methotrexate.
Okay, so now currently the patient is quite well off steroids and stable on MMF and come back to his normal life. So that is the end of our case.
And then when can you stop the immunomodulatory treatment? So if patient is in complete remission without steroid for more than 1 year, then you can consider tailing off and stopping the immunomodulatory treatment.
Okay. Thank you. At this point, I would like to acknowledge the patient who has been kindly giving the consent for the presentation of his photographs and the details, and also to my mentor, Dr. Uttara Disanayaka, for guiding me for this presentation. Thank you.
Thank you both for that engaging case-based discussion. Now, to appreciate our speakers, I would like to invite over the President of the Sri Lanka College of Specialists in Rheumatology and Rehabilitation, Dr. Jayathri Jagota, to the stage to present our presenters with their certificates of appreciation. Firstly, for her presentation on unveiling the spectrum of immune-mediated myopathies, I would like to invite over to the stage Dr. Utpala Disanayaka. Secondly, for her engaging case presentation of management of a patient with myositis, I would like to call upon Dr. Madhushika Costa. Thank you everyone, and with that we end today's first symposium on myositis. Next up, we have the most weighted session of the evening, the symposium on systemic lupus erythematosus. To kickstart the first presentation of this session, I would like to now invite over Dr. Chaturika Dandeniya. Dr. Chaturika Dandeniya, MBBS, MD in Medicine, Honorary Consultant in Rheumatology, is currently attached to the Teaching Hospital Peradeniya, and she is a Senior Lecturer in Medicine at the Department of Medicine at University of Peradeniya. The topic she has chosen for today's symposium is Diagnostic Pitfalls and the Management of SLE.
Thank you very much for that kind introduction, and I would also like to thank the Ceylon College of Physicians for giving us this opportunity to discuss an important topic, and a particularly interesting one, I would say, to the PG trainees, because this is a very commonly discussed case when it comes to the theory paper as well as in the clinical exam, and you come across quite a few interesting and challenging patients in your practice. So, getting it just right. So, problems when it comes to the diagnosis of lupus. So, the first part of the talk, I will discuss mainly the diagnostic pitfalls and a little bit on the management. So, I would say diagnosing lupus in a patient is like getting your soup right, because it's like the seasoning, where overdiagnosis as well as underdiagnosis can be detrimental. So, too much salt, too little salt, the soup is not right. So, similar to that. So, I will take you through the histories of 3 patients, and like going through this history and the examination and some investigation findings, I want you all to think, is this SLE? So, this patient I saw in my peripheral training at Provincial General Hospital, Badul. few years ago. So this was a 26-year-old mother of one who had been investigated before at Nurelia Hospital, who went Lama and then came and got admitted to Badulla. She had a history of 7 months, she was 7 months postpartum and had a history of nearly 2 months of fever, non-dependent facial and ankle edema, to the point at some point she had been almost having anasarca, so she needed IV albumin as well, and progressive shortness of breath. She also had loss of weight and loss of appetite and severe hyperalbuminemia. However, the UFR was normal, so there was no place that she was losing. So her bowel habits were normal, but still, given there was no place where she was losing, the liver functions were normal, so there was nothing to do with the production. So we thought, okay, maybe she's losing from the gut. That was the only possible conclusion. So she had upper GI and lower GI endoscopies done both at Nurelia as well as at Badulla. Very non-specific. The surgeons who did the scopes told us it was not normal, but we can't really pinpoint this is the abnormality. So they considered non-specific areas of inflammation. She had biopsies done at Badulla, and I'll talk about the timing later on. However, in the end, the biopsies were really non-revealing. On examination, she was also noted to have an axillary lymphadenopathy, which we biopsied, and it came back as a reactive node. And because she had an autoimmune hemolytic anemia with thrombocytopenia, which was persistent, we did the immunology, where the ANA became positive at 1 in 340 and double-stranded DNA was positive 1 in 10. We did not have complement levels by this time in the country. So I want you to remember this patient. So looks very much like SLE. I would say you would agree, looks very much like SLE. We'll see what happened to the patient later. The second patient was a 48-year-old female who was investigated for fever and anemia for 6 months at a teaching hospital. So the symptoms for 6 months, she was being investigated for nearly 2 months. Exhaustive assessment, pyogenic infections were excluded, and she was also given a trial of anti-TB because there was nothing going, but that also failed. Malignancy screening was negative. At which point she left against medical advice, again because the family thought that she was progressively worsening, and she was admitted to the Peradeniya Teaching Hospital. By this time, she was actually unable to walk. She came in a wheelchair, could not even stand up from the bed without support, and there were peripheral neurological signs suggestive of peripheral neuropathy. And when we did the nerve conduction studies, it confirmed a severe axonal type polyneuropathy. She had no hemolysis, although had a persistent anemia, and we also repeated the bone marrow biopsy to see interval, is there any progression. The only thing it revealed was anemia of chronic disease, nothing else. So again, while in the ward, she developed bilateral toe tip ulcerations. So these were almost like gangrenous patches at the tips of the toes. And we sent an ANA which was positive, 1 in 340, nuclear pattern but not homogeneous. So obviously double-stranded DNA was negative. However, the complement C3 and the C4 levels were very low. So this is a pretty strange case. So she has fever, anemia, but not due to hemolysis, only anemia of chronic disease, severe axonal polyneuropathy, ANA positive but DSDNA negative, and the complement levels were very low. It doesn't really sound like SLE, I would say, but something is going on. And the third story was a 13-year-old girl who was referred to us from the pediatric ward at Peradeniya. She had a diagnosis of rheumatoid factor positive polyarticular JIA, diagnosed only 3 months before she was referred to me. Was under the pediatricians they were managing in the clinic, but why he referred to me was she was admitted because for further evaluation of new development of palatal ulcers, photosensitive typical malar rash, non-scarring alopecia, vascularity crash on the palms and soles, fever without another identifiable cause, and a persistently high ESR above 100 millimeters in the first hour with a normal CRP. And the C3 and the C4 levels are both very low. Actually, the C4 level was less than 5, so both were very low. However, the problem, like why they thought, okay, getting a second opinion may be better, is because ANA was negative. On repeated testing, the anti-nuclear antibody was negative. So all the rest sounds like what else could it be, like SLE. However, the ANA was persistently negative, so that was the reason for referral. So keeping these 3 patients in mind, if I ask how are we going to make sure that whether these patients have SLE or not, I ask the trainees this question frequently, and the answer has unchanged over time, I would say. Apply the criteria. You apply the criteria and see whether these patients have SLE or not. So we'll do that and see. So there are several criteria in use. Like you would have heard about the 1997, that was the earliest criteria that came out, is ACR criteria, which really needed change. And it changed in 2011 with the SLICC criteria. But then 2019, even that was modified. This is actually a much better preferred criteria because it is a weighted criteria where you give a mark for each of the positive symptom sign or the investigation depending on how specific it is. So according to that, when I applied that, the first case of the female who came with the postpartum period, severe hypoalbuminemia, so she is classifiable as SLE. So she has a score of 12. So in this one, score of 10 or above would be classified as SLE. The second patient with severe axonal neuropathy, anemia, fever, high ESR is not classifiable as SLE because none of these are in the classification criteria. The last patient, could it be anything but SLE? Cannot even be put into the criteria because she's ANA negative, because the 2019 criteria say that absolute entry criteria is that the patient should be ANA positive. Right, so keeping this in mind, I'll take you through what happened to the three patients. So the first story of the patient who seemed like a classic SLE and the classification criteria were positive. So I told you that we did the upper GI and lower GI biopsies, and pending the biopsy report, because she had a very small child, she asked, can I go home? And we said, yes, come back with the report to the clinic in 2 weeks. She didn't last until then. 1 week after being discharged, she presented to the ETU there with severe shortness of breath, with massive pleural effusion. So the doctors who saw her told us that she had white-out lungs on the chest X-ray, complete bilateral severe pleural effusions. And as indicated there, the respiratory physician there very helpfully conducted a video-assisted thoracoscopy which showed multiple pleural nodules. And on biopsy, this came back as non-Hodgkin's B-cell lymphoma, mature cells. That's why the lymph node biopsy was reported as reactive, because without immunohistochemical staining, you cannot be 100% sure ever. So think, she was ANA positive, dsDNA positive, everything else looked like SLE. So remember that lymphoma is a great mimicker. It can come back as anything. So why we didn't start this patient on treatment? As a SR, I was convinced this was SLE. I was asking my trainer, why are we not starting her on the treatment? But he told me was like, something doesn't feel right about this case. My gut feeling is that this is not SLE. Why don't we wait for the histology and then decide without jumping the gun? And he was right. So the second story, so remember that was classified as SLE according to the criteria. The second story of the patient with severe axonal polyneuropathy, we decided, okay, something autoimmune is seriously going on. So I made a daring decision. We are going to diagnose this as SLE clinically. Started the patient on cyclophosphamide on clinical grounds. This patient made a complete recovery. She's in clinic follow-up now. So she came on a wheelchair, unable to even stand up, and she's now walking to the clinic. And the third patient, I don't have any other alternative diagnosis. So she's a classic picture of SLE. So even though the ANA was negative repeatedly, it cannot be anything other than SLE. So this brings us to the question, criteria or no criteria? So there are criteria. They tell us to apply. So what do we do with the criteria? So this is the so-called the journal article where this 2019 criteria first came out. And I want you all as PG trainees to remember that when you read guidelines, don't just look at the tables and memorize the table. You need to read the small print as well. So the footnotes, the small print, and this is part of the discussion. So in this discussion, it says, using ANA as entry criterion means the new criteria cannot classify SLE among patients who are persistently ANA negative, while possibly also distinguished by lower cytokine levels and lower efficacy of immunomodulatory treatment, such a subgroup of patients exists. So there are patients who have typical SLE, however, they are going to test negative for ANA repeatedly. And the most important part, in between the two yellow lines, it is important to stress that classification criteria are not designed for diagnosis or treatment decisions. They should never be used to exclude patients who do not fully meet the criteria from receiving appropriate therapies. More importantly, diagnosis of SLE remains in the purview of an appropriately trained physician evaluating an individual patient. So remember that SLE remains a clinical diagnosis. The criteria are there for you to decide whether this patient is going into a clinical trial for SLE or not. Trying to make a heterogeneous population as homogeneous as possible. That is the place for criteria. So, management of SLE. If I start talking, I can talk for one whole day because it's not an easy topic. So, what I thought was I'll talk to you about a few principles. So, a simplified guide to the management, just 2 slides. Again, it's like seasoning the soup. The correct ingredient without using inappropriate ingredients, such as my son when he makes salads, puts in everything he can find, it's going to make it unpalatable. And also the correct amount of the appropriate seasoning. You should not put too much or too little. So the correct drug, correct dose, and the correct timing. In the 50s, it was steroids, and more steroids, because that's the only thing that we had. Because with the invention of the steroids, actually the management of SLE and other rheumatological diseases completely revolutionized. Because before that, there was no treatment. Patients were dying. So compared to no treatment, steroids are much better. We had to admit that. However, it took us decades to realize that not really. Steroids are killing. So it's not the best treatment. It does not really modify the disease course. So it took us decades. We are no longer in the 1950s, so why do we stick to the steroids, and more steroids? We now have much better treatment options. There are a lot. You have IV treatment, you have oral treatment, and then you have the other immunomodulatory therapies like IVIG and therapeutic plasma exchange. So it's no longer just the steroids. So when choosing the correct option, there are a few key questions you need to answer. Number 1, what are the organ systems affected in the patient? Because there are some treatments that work for certain organs, not for the others. This is one reason why a lot of new treatment trials for SLE keep on failing, because they think all patients with SLE are the same. They are not. For example, if you take mycophenolate, it is a very, very effective treatment for most of the major organ involvement. It doesn't work for the joints. Nobody can explain why, but for arthritis, MMF is hopeless. It doesn't work. So likewise, what is the organ system involved in this patient? And how much time do we have? Do we have time to wait for 6 to 8 weeks for MMF or azathioprine to start working? Or is this going to be used, do something now or the patient dies? So how much time do we have? And what is the renal functions, mainly to decide what is the best treatment and which dose? And is there superadded infection? Particularly in our setting, when patients come with like protracted histories, investigations are not readily available, so they keep on being investigated in the hospital until they develop a nosocomial infection by the time we diagnose SLE. And now what? Do we treat the infection? Do we treat the disease? So is there superadded infection? And all the other issues such as fertility issues, something that very commonly comes up in the discussions with PGs, they are secondary. Before having a baby, the patient must survive, right? Live and survive this attack and then think about whether you can have a family one day. So that is secondary. So the appropriate dosing is very, very important. So the steroids, when it comes to steroids, the lowest possible dose for the shortest possible duration. And remember, this is something I heard from an expert in this field. There is nothing called a safe dose of steroids or a physiological dose of steroids. They are toxic at any given dose. And the induction regimes of parenteral immunosuppression, particularly like when in severe disease, acute severe lupus, the patient might need parenteral treatment because, like I said, we don't have time to wait 6 to 8 weeks. In such cases, it is always better to be decided by someone with adequate experience in managing acute severe lupus, because guidelines will take you only so far. Beyond that now, if you take rituximab, is there evidence for rituximab in the management of SLE? The answer would be no. All the major trials that were done for rituximab in lupus have failed so far. But do we use rituximab in lupus? The answer is yes, because we know for certain disease manifestations it does work. But then in which dose? which frequency. You ask a hematologist, rheumatologist, and a nephrologist, they'll give you 3 different answers. Because based on what we are treating, and based on the patient, the severity of the disease and all that, we change regimes. So better to ask a specialist. When it comes to steroids, do we go for 1 gram? So myositis is different. They are like you are trying to put down a fire. Yes, so in myositis, they still go with the 1 gram dosing of methylprednisolone. Not in SLE. We do not exceed the dose of 500 milligrams per dose unless in exceptional circumstances. And the weight or the BSA adjusted correct doses of oral DMARD. So when you are doing clinics, please pay attention to that, because we know all of you do see patients on DMARDs in clinics. So don't keep them on micro doses of medications and keep on adding other medications because the first one is not working. So you titrate 1 DMARD to the maximum tolerable dose or the maximum dose that is advisable. If it doesn't work in 3 months, you switch. Don't keep on adding because you're adding on toxicity. So the correct doses like induction for MMF 2 to 3 grams a day, maintenance 0.5 to 3 grams a day. So these are like, if you just go and search on the internet, all this is there. No need to memorize. Just know that you need to go for the correct dose. So if your patient is not responding, think, is the patient on the appropriate dose before switching. So the take-home messages. Criteria in SLE are for classification purposes only and should not be used for the diagnosis. The diagnosis remains clinical by an appropriate trained physician. You saw like how things that look very much like SLE turn out not to be SLE and vice versa. Steroids are not the mainstay of management of SLE anymore. It is useful but also harmful. Pulse steroids should not exceed 500 milligrams of methylprednisolone per dose, except in exceptional situations based on the clinical judgment. The best treatment modality in a patient with SLE depends on the disease severity, the pattern of organ involvement, and the comorbidity. So there I would stop the short talk on SLE, and I would hand over to the next speaker. Thank you very much.
Thank you, madam, for that kind and highly educational session on SLE. Next up, we have a case-based discussion on systemic lupus erythematosus. And to introduce our patient and to do the case presentation, I would like to invite over Dr. Sanjeevani Amararatna. Dr. Sanjeevani is a graduate from the Faculty of Medicine, University of Peradeniya, and she is a registrar in medicine attached to the Teaching Hospital of Peradeniya.
Thank you for the kind introduction. Good afternoon, everyone. I am here today to present the history regarding the mystery of febrile diarrhea. My patient is 22-year-old female. She presented with fever, loose stools, constitutional symptoms, and progressive shortness of breath since 12th of October 2025. She presented on day 17th of illness. The fever was high-grade fever along with chills and drenching night sweats. She had arthralgia, which involved bilateral symmetrical proximal interphalangeal joints. There were no other joint involvement. She denied morning stiffness, joint swelling or deformity. She had frontal headache, no photophobia, and no altered behavior or convulsions. On day 15th of illness, she developed diarrhea. Initially, it was 12 times per day, which was small amount and watery in consistency, and occasionally it was mixed with mucus as well. Later, the frequency became up to 30 times per day, which was watery but little bit thicker than the initial episodes, and which was large volume as well. There was no blood, and it was associated with lower abdominal cramping pain, urgency, and urge incontinence. She has noticed bowel opening most of the time shortly after meals. There were no vomiting, abdominal distension, jaundice, or upper abdominal pain. As you can see in this picture, early in the illness, she has noticed lips becoming darker, swollen lip, along with generalized body swelling. On day 17th of illness, she developed rash, which was papular rash on an erythematous base. There were no pruritus, and the rash involved generalized, excluding face, palms, and soles. It was settled in 4 to 5 days' time, and there was no photosensitivity either. She had progressive loss of appetite and loss of weight, which was 10 to 15 kilograms over 3 weeks. And she had progressive shortness of breath with a non-productive cough, and she had orthopnea, paroxysmal nocturnal dyspnea, and bilateral ankle edema. Intermittently, there had been intermittently worsening alopecia since 2019. She denied oral ulcers, Raynaud's phenomenon of photosensitivity. There was no proteinuria, hematuria, or oliguria. She denied pleuritic type chest pain. About the past medical history, which is starting from 2019, where she was evaluated for thrombocytopenia and polyarthralgia, and that time she was diagnosed as ITP and she was defaulted. Again, 2024, she reported with recurrence of polyarthralgia and increased hair loss, where she was underwent several investigations including ANA, which was positive, nuclear fine speckled pattern. Then rheumatoid factor, which was negative, and she was diagnosed as undifferentiated connective tissue disorder, and where she was started HCQ, and she again defaulted after 3 months as she was improved. She didn't underwent any surgeries, and there was no significant allergies. She didn't have family history of autoimmune diseases, malignancies, or heritable metabolic diseases. She consumed Sri Lankan traditional rice-based diet with adequate calorie and protein intake. She was not on regular medications. She had irregular menstrual cycles since 2019, and she had amenorrhea for 6 months preceding the admission. And she denies about the heavy menstrual bleeding, or she denies being sexually active. She is unmarried with no immediate plan for marriage. Income is adequate and having good family support. Move on to the examination. She was conscious and rational, and she had significant non-scarring alopecia on admission. She was not icteric, not pale. As I demonstrated earlier, her lips was swollen with darkening and visible inflammation around the vermilion border. Her tongue was whitish coated. There was a periorbital swelling and bilateral significant pitting ankle edema. There was no malar rash. Generalized papular rash on an erythematous base was present. There was no lymphadenopathy, no joint swelling, tenderness, or deformed joints. She had tachycardia throughout, which was around 120 beats per minute, which was regular. That was lasted for 2 weeks and resolved only with the definitive treatment. On admission, blood pressure had been normal, but towards the latter part of the disease, blood pressure had gone up to around 150 by 100. Her JVP was normal. There was no murmurs. Heart sounds were normal. She was dyspneic and tachypneic with the respiratory rate 25 to 30 breaths per minute. Saturation had been 90 to 92% on room air. Her breath sounds were initially equal with good air entry. Then bilateral breath sounds were reduced gradually over time. Fine crepitations were developed over time up to the mid zones. Abdominal and neurological examination was unremarkable. Move on to the investigations. As you can see in this chart, there are significant leukocytosis with lymphocytes predominant. Towards the latter part, she developed anemia and thrombocytopenia. We did blood picture repeatedly, which they have documented as there was no MAHA. There was evidence of infection or inflammation and elevated total count with lymphocytosis, reactive lymphocytes, and neutrophil left shift. CRP had been high, which was around 50. Procalcitonin on admission, which was high, 3.72. ESR had been normal. Electrolyte and renal function tests were normal except mild hypokalemia. There were transaminitis, ALT more than AST with normal bilirubin and significant hypoalbuminemia. Creatine profile on admission had been normal. Towards the latter part, it was deranged. INR was 2.5 with normal APTT. Serum triglyceride had been normal. Ferritin was little bit high. UFR on admission, there was proteinuria. UPCR was 103. Towards the latter part, proteinuria was settled and creatinine was normal. ECG showed sinus tachycardia. There was no features of pericarditis or myocarditis. Troponin I had been around marginally elevated. 2D echo we did twice. First one we did as a bedside during ICU stay during the active clinical signs and symptoms, which was normal. No evidence of pericarditis or myocarditis. Repeated proper 2D echo done and which showed mild MR, mild TR with ejection fraction 60%. Unfortunately, cardiac MRI was not available. This is the chest X-ray. You can see significant bilateral pleural effusion with pulmonary edema. Ultrasound scan abdomen, pelvis and lungs. The first one was normal. The second one, mild hepatosplenomegaly with bilateral segmental consolidation and bilateral patchy subpleural consolidation associated with bilateral pleural effusion in the visible lung fields. Stool full report, there were 90 to 100 pus cells with 2 to 4 red cells, fat globules, reducing substances and Clostridium difficile toxins were negative. We did colonoscopy which showed inflammation over superficial mucosa throughout the scope length. Histology reported as acute colitis of moderate severity, probably in resolving phase. Chronicity not seen. Blood culture, urine culture and stool culture was negative. The bowel culture, the Klebsiella pneumonia was isolated following ICU stay and respiratory physician has decided not to treat for the Klebsiella pneumonia. We did complement levels on admission which was normal, but with the persisting of symptoms and worsening of symptoms, we repeated the complement levels in 1 week apart which showed significant low complement both C3 and C4. ANA showed nuclear pattern was positive, 1 in 85 in speckled. Cytoplasmic pattern was negative. ANA which was done on 2024 which was significantly positive, nuclear homogeneous 1 in 1280. ENA panel had been negative. So I'll be keeping some questions with you all. Do we have a diagnosis? Why did she develop a coagulopathy? Is it DIC or liver failure? Any thoughts about the rash? Why is it important to know why she defaulted treatment and follow up twice before?
Thank you, Sanjeevani. Thank you, Sanjeevani. So that was a very interesting patient we had only a couple of weeks ago, actually. So looks very complex, sounds very complex. She came with a diarrhea and then there is now evidence of multi-system involvement. Actually speaking, it's not that complex once you get the snake from the correct end, I would say. When you hold it from the correct end, it doesn't become that complex. Actually, everything has a pretty simple explanation when you look at it. But I would start from here. So the diarrhea, that was the presenting symptom. So the evaluation of the diarrhea was everything in this case, I would say. In the beginning, now Sanjeevani gave a very comprehensive assessment of the diarrhea. In the beginning, it was only about 15 times a day, small volume, like low volume diarrhea, watery, occasional mucus. What does that tell us? Where is it originating? Large bowel or the small bowel? That's a large bowel diarrhea. In the beginning, it was only a colitis. But later on, the diarrhea frequency went up to about 30 times a day, very large volume. So actually speaking, like she was being treated with, what was that? Buscopan, was it?
Buscopan.
Yeah, she was being treated with Buscopan at the ICU because the diarrhea was not settling. But remember, that is, you are just suppressing the symptom. what is happening. You are telling the bowels not to move, not that don't produce. That's what you are doing. So like we stopped the buscopan and just to evaluate after being referred like how this diarrhea was, it was unchanged. So now the frequency increased to about 30 times a day and it is thicker now with occasional undigested food and everything. And now it is large volume. So now where is it coming from?
Small bowel.
It's now small bowel. So now you should see it's pan bowel involvement, I would say. The large bowel and small bowel are both involved. Very severe diarrhea. So actually speaking, everything else will start falling into place when you figure this out. It's the large bowel as well as small bowel diarrhea. So I'll come to the fact about do we have a diagnosis in the end. I will start from the rash because to me that was the most interesting part. And I'm thankful that the patient had the rash because that's when it was decided, okay, the rheumatologist, it's better maybe to consult and see what the hell is going on. Although it had nothing to do with her condition. Like, did you see the rash? Can you see the photo again, Sanjeevani? She very correctly described that as a papular rash on an erythematous base. So this is what the rash looked like. It was there all over the trunk, the upper limbs and the lower limbs. Face was spared and it was not there in the palms and soles. So the dermatologic name for this is Miliaria rubra, a posh name for a sweat rash, a very severe sweat rash. So why this happened was because of very high fever spike. She was having 103, 104 fevers, being treated in the ICU, being covered with all the sheets and everything. So this was a very severe sweat rash. So this was the beginning, but this had nothing to do with the ultimate diagnosis. It was not in a photosensitive typical distribution, and it actually started settling only after the fever started settling. Right, and then the next question, is it DIC? So that is why like we were repeating the blood picture repeatedly because she had a leukocytosis, she had dropping counts. The HB was dropping, the platelets were dropping, and on top of that the INR was getting worse. So is this DIC? But repeated blood pictures, there was no MAHA. Even though the INR was prolonging, the APTT remained normal. Why is this? What is the explanation? Very good. It all boils down to the bowel. It's due to malabsorption, most likely, because after we started treating that, after the diarrhea started settling, INR settled without any intervention. And there was never evidence of MAHA on the blood picture, and the APTT was persistently normal. So she had a hypoalbuminemia plus the prolonged INR. These were all the effects of the malabsorption. So any thoughts on the diagnosis now? So what do we think is the diagnosis? So if you forget about the criteria, now you will see SLE emerging from the picture. If you think about criteria, okay, it does not fit anywhere. The criteria do not talk about a diarrhea. The fever fits in, the positive ANA is there, the low complements are there, but nothing much else. So this was actually a case of SLE. The initial diagnosis of ITP, so do you think that was a wrong diagnosis in 2019? No, it was right, because at that time, all that she had was thrombocytopenia. You don't diagnose SLE just for thrombocytopenia. So the diagnosis at that time was correct, and she was started on correct treatment, but she defaulted. Then the second time she was seen, she was from far away to Peradeniya. So she was seen by rheumatologist in 2024 when she went with on and off alopecia, arthralgia, not really arthritis, found to have a highly positive ANA, and the history of thrombocytopenia. You know, like the manifestations are not necessarily now. They might have occurred in the past. So history of thrombocytopenia. So she was very correctly classified at that time as having an undifferentiated connective tissue disease. That means something autoimmune is going on, but we can't put our finger on and say this is the exact autoimmune disease. So it's not differentiated. So you call that a UCTD. Again, the diagnosis was correct because at that time there was nothing to say this was SLE. And she was started on the correct treatment, which is hydroxychloroquine, to which she responded and she defaulted. So I had to ask her, why did you keep on defaulting? Like there were 2 chances given to you by God to save your life and you said no both times. Why? And her answer was because of the job. Unfortunately, so she worked in a bank and the bank refused to give her leave. So I said, okay, might as well give you about a 1 month leave to stay in the ICU and then the ward and then go home, rather than give him 1 day off to go to the clinic. So now she's adamant that she's never going to default treatment, hopefully. And so the diagnosis, this was SLE, a case of SLE. So what she had in the gut was what we call lupus enteritis. There are so many ways in which SLE can affect the gut, and lupus enteritis is just one of them, and I would say it's the least deadly. Because if it involved the microvasculature and it caused a vasculitis, particularly mesenteric vasculitis, that is deadly. So there you don't have time to wait. You have to act. But this is more or less benign. So if you think, not really benign, but relatively, compared to the mesenteric vasculitis. So if you think about the cardiac involvement, now what do you think? She had repeated 2D echoes which are normal, only the tachycardia, nothing else going. Bilateral large pleural effusions, features of heart failure, but the echo persistently normal. And the trop pi was only very marginally elevated. So the most likely explanation is that she was third spacing. Because of severe hypoalbuminemia, she was third spacing into the pleural and the pulmonary spaces is the most likely explanation. However, we can never exclude that she didn't have cardiac involvement. One reason why I think she had a subclinical level of cardiac involvement was the tachycardia, which settled only after starting immunosuppression. There was a persistent above 120 tachycardia, which was not related to the fever spikes. Even when the fever was down, the tachycardia was persisting. So it was not entirely due to that. So as the last question I'll pose to you, so what will you do now when it comes to the management? So I told you the principles of management, so what will you do? Steroids, definitely, because like I told you, it helps. It's very useful because IV steroids have a very rapid onset of action. So we actually started with that. Sanjini, can you show what we did with the patient?
We started IV methylprednisolone 500 mg pulses, followed by oral prednisolone 30 mg MANE. Then started MMA 500 mg BD, which up titrated in 2 weeks up to 1000 mg BD, and HCQ 200 mg BD as well. She showed marked improvement within 2 to 5 days interval, where the diarrhea settled in 5 days and fever settled in 2 days, and transaminitis completely became normal in 3 days, and proteinuria was settled in 5 days. So she came back to the clinic in last Wednesday. She was doing well.
Yeah, so that was the outcome of the patient. So we chose to start the patient on mycophenolate mofetil as the induction immunosuppression alongside the steroids, mainly because we thought we had time to wait on this because it was only a lupus enteritis. There were no other life-threatening manifestations. So we started on MMA 500 mg BD, up titrated over 2 weeks to 1 gram BD. She's very well now. And one more thing about the transaminitis. So remember that lupus can cause a transaminitis. There is something that is called lupus hepatitis that is different to the typical autoimmune hepatitis. It's a completely separate thing. So this is not autoimmune hepatitis and lupus overlapping in the same patient. This is lupus itself affecting the liver. So I had one patient who had a 7 centimeter hepatomegaly at the beginning. So we were investigating back and forth why was she having a hepatomegaly, but ultimately with treatment for lupus, actually the liver completely resolved. So it's described. It's not common, but it's described. So transaminitis is the same. So it fully resolved with that. And why Dr. Sanjivani was talking about the lips of the patient, that's also important. Because that appearance in the lips, if you read, there is something called lupus cheilitis. So SLE can affect the lips, causing lip swelling. So why we think it is the lupus cheilitis, not just the hypoalbuminemia, is because of the inflammation along the vermilion border. So the vermilion border is where the lip skin, the red color lip skin meets with the normal skin of the face. So along that border there was inflammation and the lips were also painful. It's not just the swelling. It was painful as well, and there was darkening of the skin color. So that also fully resolved along with the treatment. So this was our story about the mystery diarrhea. So all diarrheas are not infective, and she was there in the ICU because her breathing was rapidly deteriorating, the saturation was dropping, and she was having a non-stop diarrhea, had no clue what to do. So thanks to our medical team who detected the signs in time, the patient was referred in time and we were able to come out with a successful outcome. Thank you very much.
Thank you.
Thank you both for that interactive session. And now to present the certificates of appreciation to our presenters on behalf of the Ceylon College of Physicians, I would like to kindly invite over Professor Namal Vijay Singha, the incoming president of the Ceylon College of Physicians for the year 2016 to the stage. Firstly, for the presentation on systemic lupus erythematosus titled Diagnostic, Pitfalls and the Management of SLE, I would like to call upon Dr. Chaturika Dandeniya to the stage. Next up, for her presentation of the informative case of a patient with systemic lupus erythematosus, I would like to call upon Dr. Sanjeevani Amararatna to the stage. Thank you, sir. Finally, before we conclude, to give the audience a collection of clinical pearls in rheumatology and rehabilitation, I would now like to call upon Dr. Duminda Munadasa. Dr. Duminda Munadasa, MBBS Colombo, MD Medicine, FCCP and FRCP, is a board-certified specialist in rheumatology and rehabilitation who obtained the MD from the Postgraduate Institute of Medicine, University of Colombo, and he is currently attached to the Rheumatology and Rehabilitation Hospital at Ragama. He is a trainer and an examiner for senior registrars and undergraduates. He is also the past president of the Ceylon College of Physicians and the College of Specialists in Rheumatology and Rehabilitation, and he will present today his presentation on the topic of rheumatology shorts for postgraduates.
Good afternoon, everybody. Yes, it's much past lunchtime. Must be hungry, but yes, important topic for trainees who are going to do MD. My thoughts after being an examiner for last few years in MD and doing most of the time the spots or so-called the short cases, the other systems where we get a lot of rheumatology patients. So, but it can be applied to any trainee of any of the exams where you're going to get rheumatological patients. Just an overview and how to sort of tackle them, how to get prepared for this. You need to be prepared. You have a few minutes to go through and do the presentation and get marks. So generally when it comes to MD examination, it's in the other system section of the short cases. You get 2 patients, 5 minutes each for the patient, that is 3 minutes for the examination and 2 minutes for presentation or questioning. So 3 minutes is a long time when you come to the exam, so don't worry. One of the main mistakes I see is in the exam is people rush through the beginning. They look at it, it's very easy. Most of the patients you can recognize what it is, and they rush through and don't really concentrate on what to be seen. When it's easy, what we look for is whether you pick up the positives and negatives correctly. You can't just say everything belongs to that diagnosis and get away. You are going to get marked down if you say wrong things. So take time, but practice. If you practice, you will know how the timing will work out for you to see the important things, but quickly. So the questions will be where you have to make a diagnosis and give the complication if there's any. So that is the main thing we are looking at this exam at that point. So you may be asked a few clinically relevant questions if there's time, and we don't ask you generally we are asked not to ask about the investigation and treatment on that patient at that in these spots or the other system short discussion patient. You will see the patient either seated on a chair or lying down in a bed. That's the usual position. And general commands which will be on the side of the patient will be observe or examine the hands and proceed, observe the face and proceed, and observe the patient on standing or while seated, or maybe asked to look at the posture and proceed. This is related to rheumatological patient, but most of the time, even generally, it will be endocrine or some other disease which we give. Most will be given in this way most of the time. So when it comes to rheumatology, when you look at the observe and examine hands and proceed, what do you do? How do you proceed? This will be at least you'll get one patient like this most of the time in the exam. So have a general observation of the hands. Then you examine the hands on dorsal side, examine the hands on palm. Then you ask them to flex the elbows and look for the extensor surface of the elbows. And then you go for the other relevant system related to your diagnosis through the hands. Easy, but need preparation and you need this format because this is what I think is the best way to go through. It will tell you, we will not miss things. So general observations will be whether there are swelling, deformities, what is called sclerodactyly or thin fingers or puffy fingers, changes in the fingers. Are there nodes on the fingers and hand, and are there rashes? So swelling can be due to different things. It will be the joint swellings of typically in the PIP and the MCP joints, or it will be in the PIP as well as the DIP joints. You know the diagnosis in these two. If you look at it carefully, you will see the skin rash on the right side one, and of course easy. So this observation is important because you will maybe you can do the first diagnosis itself and you know what to look for. You can get dactylitis. 1 or 2 fingers are swollen, whole finger. This is not the joint. So make sure that you observe that the whole finger, including the soft tissue, is swollen. That's again, sometimes people think this is BIP swelling and goes on that, but this is dactylitis. And then you can get a whole finger swelling in early systemic sclerosis or even mixed connective tissue disease. So they are shiny. The edematous skin is seen, but the joints are normal. So these are general observations you see about the swellings. Then you go observe the deformities. Of course, these are the famous deformities, very easy. I'm not going to go show you a lot of things. But you have to describe when you see this. You don't have to say, this finger has this and this finger. Don't waste time. You say, this patient has deformities of, depending on what it is there, swan neck, boutonnieres, ulnar deviation of fingers at MCP, it's not the wrist deviation, and the Z thumb, of course. But to look, you see it's rheumatoid, don't go and say everything which is there. Again, common mistake. Just say what is, you look and find out what is there and tell only what is there. Common mistakes is they tell that you saw all this. So when they are false neck ones, we mark down. Then you see the deformities due to other things, the telescopic sign on the left upper one, the thumb in psoriatic patients, nodule osteoarthritis on the left down with the node seen, not very commonly given, but it can be a mimica, which you may be looking at something else. You can get deformities like in SLE, non-deforming arthritis, where you see deformities, but they are correctable deformities, Jacquot's arthropathy. And systemic sclerosis, because of the skin thickening, you can get this flex feature, right? So don't get misled on that, saying that this is a boutonniere's deformity, but you have to see the skin is thickened. So don't rush into things, examine systematically, that then you will come to the proper diagnosis. Again, this puffy fingers and sclerodactyly, mainly in systemic sclerosis and mixed connective tissue disease. Mixed connective is very uncommon, but systemic sclerosis is commonly given in the exam. So need to describe them as sclerodactyly, and they can have flexion due to the skin thickening. The right corner is something you might think this is sclerodactyly, but you'll notice these are very long fingers. So Marfan patients are given in this spot, so don't mislead again. Think about all the possibilities without rushing into them. And you get these changes again, the other changes in the skin with the, again I'm enlarging the same pictures for your better observation. Nodes are seen, again nodule osteoarthritis is something which you might see and you might get misled. Sometimes patient may be having that in additional feature. So, but you palpate, it's hard nodes on the joints, but it's not soft tissue swelling of the joints. And then you can get rheumatoid nodules on the extensor surfaces, and you get the gout changes in the hands, and sometimes it is seen, but again may get if you get a patient. So you can get a polyarticular gout, so think about it when you see them, but you might see a bit of a whitish, reddish swelling to differentiate. So look at these patients in your clinical practice and then recognize them. It's easier to do that way rather than looking at the pictures. The rashes you can get are some are they already been discussed here, previous patients. The psoriatic rash on the dorsum side, you get the Gottran's papules and Gottran's rash or Gottran's sign, and of course sometimes and then this is the psoriatic rash, and you get the depigmentation in systemic sclerosis, and Gottran's papules, and what is on the left-hand side is Mechanic's hands. So these are what you will see in the fingers. And sometimes the Mechanic's hands and things easily missed because people don't look very carefully, look only for the gross features sometimes. Then you ask them to turn your hands to the dorsal side. So on the dorsal. So these are observation, and now looking at the dorsum side, you look at the nails, cuticles, pulp of the fingers, skin examination, whether it's thickened or not, whether there are rashes. Maybe you can comment on dorsal muscle wasting, and then look for the joint movement, so that what we do on the dorsum side. So nail changes are very important. Psoriatic can have these various type of skin changes, not only the common ones. So any of them can be psoriatic changes. So common ones are pitting. Pitting 1 or 2 up to about 5 can be normal. You have to put a light and look at it. Don't just look at it and say. And when you see psoriatic skin rash, a lot of people say, oh, there's pitting and all that. So again, if the pitting is not there, you'll get negative marks. So make sure that you look at them, put the torch, and see whether it's multiple pits are there in at least in one nail. You can get leukonychia. You can get these red spots on the corners of the nail. Crumbling can happen. Onycholysis is commonly seen. But splint hemorrhages also can happen, and this is what we call oil drop discoloration on the line below. And then so just look at the pictures, look at the patient, and try to identify them. And look at the nails carefully when you think it's a psoriatic patient, especially. And the cuticles are important in 2 things: systemic sclerosis and the dermatomyositis, 2 diseases which we discussed today. The systemic sclerosis you get, and these changes of ragged nails, and generally the dermatomyositis you get hypertrophic cuticles, ragged as well. And erythema on the periangular region is seen in the systemic sclerosis. We don't expect exam to see whether the capillary scope to be done there or not. Pulps are important. The systemic sclerosis, you get this pitting pulps, pitting in the pulp of the tip of the fingers, again due to ischemic changes in the systemic sclerosis. They can get into necrosis, and you can have calcinosis. So these are the pulp changes in systemic sclerosis you can observe in these patients. So, and also you get this pulp atrophy, or actually the phalanx atrophy due to osteonecrosis, which happens in systemic sclerosis. So try to observe that the distal phalanx, if you think it's a systemic sclerosis, because that atrophy of the distal phalanx is a very famous sign that you see in systemic sclerosis features, which we may give marks if that patient has them. This is how you look for the skin thickening. You have to, generally the skin thickening, what is important for systemic sclerosis in the dorsum of the hand. The thickening only on the fingers is not considered as systemic sclerosis unless you have other features. So you can pinch them, or you can use two thumbs or two fingers to lift it up and see. I commonly have seen this class or nomenclature of systemic sclerosis. How they present is sometimes is a problem. So you have this scleroderma, then you have localized scleroderma and the systemic scleroderma, systemic sclerosis, and where you have limited cutaneous systemic sclerosis and diffuse cutaneous systemic sclerosis, and then there are overlap syndromes where you have thickened skin. So what is limited scleroderma is, patient with skin thickening sparing the fingers are not classified as systemic sclerosis. So fingers has to be thickened, but together with that, patient with skin thickening of fingers of both hands extending proximal to the metacarpophalangeal joints alone are considered systemic sclerosis in the first hand. So fingers has to be involved, but it should go beyond go proximal to the metacarpophalangeal joint. So it's important to look at the skin thickening in all areas. Patient with sclerodactyly of fingers, that is thickening distal to MCP joint, are considered systemic sclerosis with other features of the hand of the systemic sclerosis or with antibodies. So it's a possible systemic sclerosis which you have to think about if you don't see any other feature of systemic sclerosis. And what is diffuse systemic sclerosis? Skin thickening proximal to elbow or the truncal area, and sometimes say it's above knees as well, if you're looking at the lower limbs. If not, it is called limited cutaneous systemic sclerosis. So that's the nomenclature you have to use, whether it's a diffuse cutaneous systemic sclerosis or scleroderma, or limited cutaneous systemic sclerosis. So those are the nomenclature we expect from the trainees when they present in an exam setting, or even when you discuss patients. And then coming to examine the joints, see whether they are clinically swollen. So technique of examination is important. We see different ways of examining, but this is probably the correct way. You rest your joint, the examined joint, on either the middle or index fingers, and use your thumbs to see on the side, see whether there is swelling and tenderness. And so for PIP, DIP also same. Hold this way, and then the wrist also the same way. Use the thumbs to see whether the swelling, and the patient, look at the patient and ask whether at that point we can ask patient whether the pain is there. It may be important to look for especially the wrist joint movement, because that will be a clue that it's more of a rheumatoid or psoriatic patient with a wrist involvement. Sometimes you don't see the swelling. And then you ask them to turn their hands to the palm and look for in the palm. When you turn, you again, first before looking at the palms, look at whether the patient can fully supinate the elbows. If the limitation is seen commonly in rheumatoid arthritis, so you can comment on that. And then on the palms, you see for calcinosis, skin pitting, vascular lesions, pigmentation, and muscle wasting. Then you do the basic hand function, because whether the patient is having normal functions in a hand involved joint disease is an important thing for the management. So you turn and see whether it can be done fully, the elbow, the forearm movement, and then you look for the different changes in the skin. So you look for the digital pitting, which we have looked at earlier also, calcinosis on the palms as well, and whether there's vascular lesion like telangiectasia in the systemic sclerosis. And see whether there is Raynaud's, and also whether there is palmar rashes like in psoriatic palm rash. The basic hand functions are roller grip and the pincer grip. Roller grip, a normal person should be able to clench their feet where the pulp of the fingers can be buried in the palm. If that is affected, that means the roller grip is affected. And pincer grip is where you can put the thumb and the second finger together, like the picture, and you can also pull them together. You don't need to do that. If the patient can do that, that means his pincer grip is good. You are not going to test the muscles here, power here. And the corner one picture will show if there's a problem, how they are going to hold something. So test this. So it's both two functionally most important function of the hand is the roller grip and the pincer grip. So you can describe that in this point. And if they're affected, you can say their functions are affected due to the disease. So that's a complication we are looking at this point. To ask them do some of the next step could be flexion of at elbows, look for the skin rashes, and look for the nodules, especially the rheumatoid nodules, common site to have it. So you can do all this quickly and then go to the relevant systems. Again, look at the legs and feet whether the same changes are there. You don't have to go very thorough there if you have found things in the hands. Look at the face, including eyes, whether there's red eyes, and then any facial changes related to whatever disease you are looking, especially if systemic sclerosis, you have to look for the certain things. The scalp, the lung, looking especially at the basal crepitations and apical fibrosis. And I've seen patients being examined over the clothes when they go for the heart and the lung. Especially if you're the foreign examiner, they are bound to fail. So don't do that. Generally, we give the patients with where you can lift the clothes. You don't have to totally remove the clothes, but lift it up or open up. There will be space. You do it proper way. You don't do the full lung examination, but auscultation is needed for these complications. And as well as the heart, looking for pulmonary hypertension is relevant, and aortic regurgitation. And if you see in the dermatomyositis patient are given, then look for the proximal muscle weakness, at least in the upper limbs. And so that is how you are going to go through if you are given the hands. So start in the hands, go through the system, and then go to the relevant system, which will include the heart and the lung, and the muscle. But all that you don't look for everything. It's depend on what your diagnosis or possible differential diagnosis on the hand. And then observe the face and proceed. It can be endocrinology or it could be rheumatology. So rheumatology, it will be more like systemic sclerosis or dermatomyositis patients, which can be given. So looking for the mouth changes, the puckering around the mouth, beak nose, pigmentation or depigmentation, and back of the neck for speckled leukodermas, and look for the scalp and back of the ear rash, malar rash, and heliotrope rash, and eyes are the things, a systematic way that you can go through. So other system, it can be Cushing's, Addison's, acromegaly, hypothyroidism, ptosis, exophthalmos, myotonic phases. So these are the ones which I have seen being given. So just when you ask for the face, have a look at have a broad think in your mind, whether the face fit into any of these, and then you can proceed. So these are the systemic sclerosis changes. Again, you can always, though it's not nice for the patient to put their fingers in the mouth, that setting, but you can ask them to open the mouth and without putting in, but see whether it's sort of from the outside, whether you can fit at least 3 fingers of the patient. or even obviously it's small, you don't need to do that. So make sure the patient also not discomfort or unhygienic things are not being done in the exam because it's been repeatedly seen by the other candidates. And back of the scalp and hairline, looking for rashes are important, psoriatic especially, and back of the ear. And you get this lupus changes in the hairline of DLE type changes in the ear and the lupus. Look for the ear and the scalp margin all around the head. So this is the malar rash, DLE rash, mouth ulcers of SLE. Look in the mouth if you think it could be possible. Always look in the mouth also when they are given look at the face, because clue may be there, that's a problem. And dermatomyositis in our patients generally have this, you don't get that full, the heliotrope color, but darkening around the eyes, as well as we commonly see the forehead pigmentation in our dermatomyositis patients. The eyes also, you can say just red eye is good enough, rather than, it's very difficult in this setting to say this conjunctivitis or scleritis, episcleritis or things, but you might see this sort of haziness in the uveitis in the eye, as well as sometimes you see this, the right upper level right corner where you see the bluish changes in the sclera. This is extension into the scleromalacia of rheumatoid arthritis. So something important to pick up even clinical, because that means that patient will be very likely to lose their eyesight quickly. So those are the eye changes you may need to look quickly. And of course, look for when you observe the face and proceed, it could be other systems which you have to think about, which I told you earlier. So then other command can be just observe the patient. Patient be seated or lying down, generally given seated. Observe the patient. So you may generally look at again the posture. Generally when you say observe, that is you are looking at the posture generally. And then you may need to stand and look at the posture and proceed. So rheumatologically, it's mainly the axial spondyloarthropathy that you may be given in this way. If their hips are involved severe, they may be sitting on the edge of the seat, which will give you a clue. And they are difficult to stand right back onto the seat. And on the standing, you will see the question mark posture. But when you say observe the standing, observe the posture, it could be short stature in Turner's patients, or it could be tall Marfanoid patients. So those are also given in exams in the MD sometimes for this short case for the spots or the other system. So seated, as I told you, if you have the hip and the severe spine involvement, they will not be able to sit back. If they ask to sit back, they lean forward, and when they stand, you get this question mark posture. Observe from the side. And of course, Turner's and Marfanoid features you should know, and if you detect that, just go through all the things that is needed in that posture. Then you start with the neck, chest, and back movements. The neck, it's important because you should know what the normal neck movements. Flexion, trying to tug your chin against the sternum, looking up where the forehead comes straight up, and sideways, trying to the ear to touch the shoulder tip. So those are change ones if you are normal. If they are affected, that means the cervical spine is affected. Rather than saying that I want to check the wall to tragus, it's not very important, because wall to tragus, there's no normalcy. How do you know whether it's only for the management or long-term follow-up that we need to do that. So in an exam where you are supposed to make a diagnosis, it's not important to look the wall to tragus, but of course what you can say is, I want to see whether the patient can put their head against the wall. But that can be checked by just doing the range of movement. And then chest movement is important. That is where chest expansion should be done to see whether thoracic involvement, if you think this ankylosing spondylitis or axial spondyloarthropathy. And when you bend, most of the time I see in the candidates trying to bend and ask the patient bend and then see whether they can touch the floor at least below towards the ankle. That's not the important thing. When they bend, observe the spine. The normal curvature of you get curved spine or when the normal person bend. And ankylosing spondylitis, you will see this straight spine when they bend also. So that is the observation, and that is the clue that the patient is having lumbar spondylosis, spondyloarthritis, and then you can ask for show burst to be done. We probably say you don't need. If you think it is abnormal, that's abnormal, because time is a problem here if you go through all that, but you should ask. So here's the picture again. You have a question mark posture, and if it's this is a patient with a normal one with a curve, and ankylosing one will have this straight spine when they bend. And of course, you should know what show burst, and you can ask for that. You can try to do it, and probably we might stop it, saying time may be a problem. If you want to do the SI joint thing, I have seen again patients standing and you are pushing on the spine and seeing tenderness. Standing, you will not get the tenderness most of the time. You have to put the patient on bed and do it if you want to do it. So do it in proper way. Learn how to look for the SI joint. There are a lot of tests. It's generally, we are not going to press on that too much. You can say that you want to put and see for the SI joint examination and the hip examination. Again, time is a factor. And if you are doing it just for your learning experience, do the hip movement also. And then you go for the other system. Look for the eyes changes, scalp, skin, and nails. From the posture, you have to come down and see whether psoriasis is involved, and then go for the lung and heart, as I told you before. So, a short thing going through, trying to cover a lot of things, but trying to give you some way of doing it in systematically, getting through this part of the exam or doing it. And maybe you can use it in your clinics. It's not for an exam only. In your clinics to detect problems when they have a patient comes with a back pain or any other hand problems. So in summary, patient for short discussion rheumatology, what you need to is, you'll be asked to observe or examine hands and proceed. Observe the face and proceed. Observe the patient on either standing or seated, and then, but you have to get standing and proceed. So go through the general observations, and when you present also, you present like that. So I will observe this patient have a deforming arthritis, or whatever the way you have seen it, and then go with the specific things by examine the dorsum of the hands and palms and elbow. Then you do the whether the extended surface of the forearm and then relevant areas. So these are the ones you have to again look at it. So when you present your finding with important negative findings also for leaning towards a diagnosis or differential diagnosis. That's your aim. And then you say the diagnosis is likely this, whether the patient have active disease by looking at, like example, rheumatoid, and whether they have tender joints, swollen joints, and complications in the joints as well as lung, heart, and eye, and other things. So that's your presentation in 2 minutes time. So thank you. Hopefully that's helpful as from the examiner's point for you to handle that situation in your exam. Thank you.
Thank you, sir, for the presentation. Now to present the certificate of appreciation to our speaker, I would like to invite Dr. Lilanthi Subasinghe, the Secretary of the Ceylon College of Physicians, to the stage. For his presentation on rheumatology shorts for postgraduates, thank you to our Dr. Duminda Munidasa for his contribution. Thank you, everyone. Before we conclude, I would like to now take time to thank all the parties that made today's session an immense success. First, my thanks goes out to the incoming and the outgoing presidents of the Ceylon College of Physicians, and also to Madam Dr. Jayatri Jagoda, the President of the Sri Lanka College of Rheumatology and Rehabilitation Specialists of Sri Lanka, for gracing today's occasion. The speakers, presenters, and all relevant resource persons and the sponsors of today's session are also remembered with much gratitude. With that, we close today's session on Speciality Update of Rheumatology and Rehabilitation organized by the Ceylon College of Physicians. Hope to see you all again in another educational specialist update next year. Wish you all the very best. Thank you.